and it's my pleasure to welcome you all today evening for this, I would say, very, very important webinar on something on ART. And I know we all live in pandemic times. We are all searching for this word called as new normal. And it's my pleasure to introduce and invite Dr. Shweta Tumula ma'am. The topic for the day is improving success rates in ART. We're all doing ART, but there are a lot of factors and fulcrums which go around improving the success rate. So with this, I would like to give a small introduction about ma'am. Ma'am has done MBBS and MS OBG. Ma'am is the current director and ART specialist, Sridevi Fertility Center, Hyderabad. Ma'am has completed her advanced ART training at Cleveland Clinic, Cleveland, Ohio, USA. Ma'am also has a fellowship in reproductive medicine from the University of South Alabama, USA. Ma'am has also an ART fellowship at the Center of Reproductive Medicine, Florida, USA. Specific interest areas of ma'am is ART, different IVF protocols. Ma'am has been a faculty in various national and regional forums. With this, I would like to hand over the session to ma'am. Ma'am, over to you.
Thank you, Kiran. Thank you for that. Hello, a very good evening to all of you. Hope all of you are safe and enjoying time with your family. So, shall we start? Share screen? Yeah. Right. So, today we will be discussing on a very important topic of improving success in ART. There has been a tremendous advancement in the and also research going on in the field of ART, our stimulation protocols, and also the techniques of ART. They have been getting refined day by day. So with all these advances incorporated into a daily practice, can we improve our success rates and also give the best to our patients in the least possible time? So let's talk on all these advances in this session of improving success in ART. So I would like to introduce to you the concept of time to pregnancy as a measure of success, define clinical success measures in ART, introduce the concept of cumulative live birth rate as an outcome measure, explain how to personalize controlled ovarian stimulation protocols, appraise the importance of embryo euploidy for implantation and pregnancy. Time to healthy singleton delivery is the most important thing to be taken into consideration while we are making decisions related to infertility treatments in women of all ages. It is important that we provide these fertility treatments in a timely manner, avoiding over or under treatment. Considerations of time are of particular importance when we are treating women aged more than 35 years because there is a decline in the fertility observed, as all of us know, with age, and also particular consideration should be given in women with reduced ovarian reserve. International prevalence of infertility is around 4 to 14%. Wide disparities exist in the quality, availability, and also delivery of infertility services between the developed and also the developing nations. As you can see here, 10% of the populations in the United States is utilizing the ART services. In the United Kingdom, it is 33% of the population utilizing the ART services. But when it comes to India, only 1% of the population is utilizing these ART services. This may be because of the social stigma related to infertility, and most importantly, it is the financial burden or the cost that comes with these infertility treatments. So many of these countries have included many of the fertility treatments in their national health policies. We also hope India should also include some of these infertility treatments in the health policies, so that many of the needy infertility patients, they take up these fertility treatments and benefit from them. Counseling is an important integral part of an ART program. So while starting on with an IVF program, the patient should be counseled regarding the physical, the psychological, emotional, and also the financial factors that go with the infertility treatments. So this is the study which was conducted related to the dropout rates in Germany after an IVF program. So this clearly shows that the dropout rates has increased from 39.9% after the first cycle to 62.2% after the fourth cycle. So this indicates that there is an enormous stress and also frustration which is associated with these infertility treatments. So by taking into account these high dropout rates, we need to think that we have to maximize our outcomes per treatment, per cycle for these patients, and also to reduce the time to pregnancy so that we take out the stress and also frustration related to the infertility treatments. So whenever we are performing an IVF cycle, we have many number of outcomes from it. So we are more happy when we have more number of oocytes. We are more happy when we have more number of mature oocytes, when all our oocytes get fertilized, and we have good day 3 embryos, when we have good beautiful blastocysts, and also we are more happy when we have more number of euploid embryos. But what is, we have these many number of outcomes, but what is success in ART? What does it mean? Is it that seeing 2 pink lines on the urine pregnancy test kit is a success? Or is it the clinical pregnancy rate that we need to know? Or is it the ongoing pregnancy rates that we need to see? Or is it the live birth rates that we are interested in? So what is success in ART? From the patient's perspective, it is having a baby. What is success in ART according to the ART specialist? So we have a classical or the traditional definition for ART success. It is the number of live births per cycle, per oocyte retrieval, per embryo transfer. But because there have been an advancements, or our controlled ovarian stimulation protocols have been refined over time, and also there have been a tremendous improvement in the cryopreservation programs, making more number of frozen embryo transfers successful, we have been able to redefine our success in ART. So how did we redefine our success in ART? Is by adding the cumulative live birth rates. Cumulative live birth rate is the live birth resulting from one initiated or aspirated ART cycle, which includes all the fresh and also the frozen embryos that are transferred, which translates into one live birth. So by increasing this cumulative live birth rates, we can decrease the time to pregnancy, which is the time taken to establish a pregnancy measured in months or in numbers of menstrual cycles. How do we increase our cumulative live birth rates? So how can we do this? So it is by improving our primary outcome of our ART cycle. So what is the primary outcome? It is the number of oocytes. Because oocytes serve as a surrogate marker for live birth rates, we have to improve the number of oocytes. This is a study done by Sej Kamal Sankara showing the association between the number of eggs and also the live birth rates after an IVF treatment. Here from this figure, you can see that by increasing the number of oocytes, with increase in the number of oocyte number, there is an increase in the live birth rates. You can see clearly from the picture that from 1 to 5, 5 to 10, and also 10 to 15, there is a linear association with the live births. And after it reaches a certain point, there is a decrease in the live birth rates. So this is because this study has been done only in the fresh cycles. The frozen embryo transfers were not taken into account. But what we need to take into account here is the increase in the number of oocytes. There is an increase in the live birth rates. There is also the other study over here which shows the similar association between the oocyte number and also the live birth rates. Here, as the oocyte number increases, there is also an increase in the live birth rate, and it drops after a certain number of oocytes are reached. But when we are trying to increase the oocyte number, we have to take into consideration the patient's safety. That is, by decreasing the OHSs, we have to increase our oocyte numbers. So these two studies have taken GnRH agonist protocol, and also they have considered only the fresh cycles. So this is a study in which they have looked into the number of oocytes retrieved, association between the number of oocytes retrieved, the cumulative live birth rates, and also the female age. From this picture, you can see that with any female, with any age of the female, maybe it 18 to 29 years, 30 to 34 years, 35 to 39, or more than 40 years, with increase in the number of oocytes retrieved, there is an increase in the live birth rates. So even with the 45, even when the age is 45 years, the number of oocytes retrieved are more, then the cumulative live birth rates are more. So this shows that the maximum cumulative live birth rate was observed when around 25 oocytes were retrieved in women with 18 to 35 years of age, and around 9 oocytes retrieved in women more than 45 years of age. So do we have an association between oocyte number and embryo euploidy? Yes, there is an association with oocyte number and embryo euploidy. As you can see from this study, with increase in the number of oocytes, the embryo euploidy also increases. So here we can see that the mean number of oocytes that are needed to achieve one euploid blastocyst with age. So when the age is less than 35 years, 6 oocytes are required to achieve that one euploid blastocyst. But when the age is between 39 to 40 years, 10 oocytes are required to achieve one euploid blastocyst. Similarly, when the age is between 42 to 43 years, 16 oocytes are required to get one euploid blastocyst. This was a study conducted by Antonio Lamarca, in which he has seen about 578 infertile couples, and they went for pre-implantation genetic screening also. But here the important thing is they have shown an association between the oocyte number and also the euploid blastocyst. So as you can see here, the bottom line, which shows the mean number of euploid blastocysts. Here you can see that whenever there is an increase in oocyte number, the number of euploid blastocysts also increases. So increase in the oocyte number, there is an increase in the euploid blastocysts. The middle line, whenever you say this, shows about the euploid rate. So this euploid rate in this study is around 30%. So what is euploid rate? Think if, for an example, if a woman has 5 oocytes and she has a euploid rate of 30%, and the other woman, if she has 10 oocytes and she has a euploid rate of 30%, the woman who has a larger number of oocytes, she will have more number of euploid blastocysts to transfer. So the above line, which shows the probability of having at least one euploid blastocyst. This also, when we see with increase in the number of oocytes, the probability of having one euploid blastocyst increases. It's very simple. Increase in the number of oocytes leads to increase in the number of euploid blastocysts. So we have more number of euploid blastocysts to transfer. And also this is a large study which has looked into the cohort size of the embryo and also the embryo euploidy. It was from 70 North American clinics. They have done embryo biopsies on day 3 and also in the blastocyst stage, and they have done a CGH analysis also. This analysis has been stratified for female age and number of available embryos. So according to this study, they have done a separate 3-day embryos and also the blastocysts. They have divided them into 3-day embryos and also number of blastocysts. So here they have looked into the number of embryos, that is the embryo cohort size, and also the euploidy rate. So the figures which you are seeing in the boxes are the euploidy rates and also the female age. So here you can see that for any particular female age, take for example 35 years, when you look with increase in the number of oocytes, the euploidy rate remains almost the same, plus or minus, but it's not so significantly higher or lower. It remains almost the same. That is, the embryo cohort size is independent of the euploidy rate. However, many number of embryos you have, the euploidy rate remains the same. So this we all know, but the most significant thing here is with increasing age, the euploidy rate decreases. Either it may be day 3 embryos or number of blastocysts. With increasing age, the euploidy rate also decreases. So we have to see that there is this likelihood of increasing the euploidy rate with one euploid blastocyst. So aneuploidy rate usually increases with age, and if for patients more than 42 years, the aneuploidy rate is the highest. It is around 85%. Is there any correlation between the embryo morphology and also the implantation and the live birth rates? Yes. The embryos which have a good morphology and they have a good implantation rates and also the live birth rates, and blastocysts which have a good quality, they also have more implantation rates and more number of live birth rates. So obviously day 5 blastocysts have more live birth rates, and also the cumulative live birth rates are higher with day 5 blastocysts. So this was a study done by FSH Sankara, where they have looked into the association between the response to ovarian stimulation and miscarriage following IVF. They have looked into the preclinical outcomes, the clinical outcomes. Then we have here they have looked into the association between the number of oocytes, the clinical miscarriages, age, and also the clinical miscarriage. As you can see from the picture here, women who have less number of oocytes are having a higher number of miscarriages than women who are having a more number of oocytes. So here what we have to consider is miscarriages are mostly because of aneuploid embryos that we are transferring in. So more number of aneuploid embryos we get, there are more number of miscarriages. So here the same thing translates. Whenever we have more number of oocytes, we get more number of euploid embryos. So the vice versa, less number of oocytes, we have less number of euploid embryos to transfer. So whenever they have seen the association between age and also the miscarriage rates, with increasing age, there is an increase in the number of miscarriages, because the aneuploid is also increased, there is a decreased number of oocytes, and there is an increase in the miscarriage rate. This was a novel approach which was proposed by Vaughan et al., where they have looked into how many oocytes are optimal to achieve multiple births with one stimulation cycle. It is called the one and done approach, meaning the patient is stimulated for one cycle, and the stimulation protocol is followed in such a way that we get the maximum or the optimal number of oocytes from that one cycle, and we do a fresh and also the frozen transfers for the patient so as to complete her family. Here they have taken 2 live births to complete her family. So as you can see over here in this picture, if you can see, it is the same wherever we see. All the researchers, whoever has done, has got the same results with the number of oocytes retrieved and also the live birth rates. So with increase in the number of oocytes, there is an increase in the live birth rates, but these live birth rates are only to some extent, and then after a certain oocyte number, they usually fall away. But what are we interested in is the cumulative live birth rates. That is both the fresh and also the frozen transfer cycles. So number of oocytes, whenever there is an increase in the number of oocytes, there is an increase in the live birth rates. So here they have seen that whenever more than one live birth rate or more than 2 live birth rates, this require more number of oocytes, that is more than 20 or 25 oocytes. And they have concluded that one and done approach would allow almost 1/4 of our patients to safely achieve 2 or more than 2 live births with just one stimulation cycle. Most importantly, as the number of oocytes retrieved increases, the chance of at least 2 live births, that is cumulative, that is fresh and frozen transfer, increases by 8% per each additional oocyte. So this is also a large study which was done across 15 centers in Spain and Belgium, taking around 15,000 women. It is also the same thing everywhere, but they have looked into the number of oocytes related to the live birth rates and also the cumulative live birth rates. So here you can see as this light blue lines which indicate the live birth rates, they are increasing to a certain extent, but after the reach of 20 or 25 oocytes, the live birth rates are decreasing because these are taken only in fresh transfers. But when you see the dark blue bars, that are the cumulative live birth rates, which include both the fresh and also the frozen cycles, In this, you can see there is a linear association. That is, whenever the number of oocytes are increased, the cumulative live birth rates are increased. Cumulative live birth rates are higher. So we can say that with this background, we can say that number of oocytes, the result in more number of oocytes result in more number of euploid blastocysts, then we have more number of cumulative live birth rates. So by increasing our cumulative live birth rates, we can decrease the time to pregnancy for these patients. Increasingly, time to pregnancy is increasingly recognized as an important outcome to measure the effectiveness of our interventions. So whenever we are decreasing the time to pregnancy, so that effective our interventions are. So what do we need to decrease this time to pregnancy? We increase the number of oocytes so that there is an increase in the cumulative live birth rate, and also there is a decrease in the time to pregnancy. So while in this thing to improve our cumulative live birth rates and decreasing the time to pregnancy, we need to optimize our follicular recruitment. Why we need to optimize is to avoid a poor response or a hyper-response, and also to avoid the extremes of ovarian response, to reduce cancellation rates, and also to reduce OHSs. What should be the goal of our ovarian stimulation? It is to maximize efficacy by increasing the cumulative live birth rates. At the same time, we should reduce the complications and risks by decreasing the cycle cancellation, decrease the treatment burden, and also decrease OHSs. So whatever protocol we follow, stimulation protocol we follow, it should be simple, it should be cost effective, it should have minimal side effects so that it improves the patient's compliance, and it should give the best outcomes for us. But how do we get these best results from our stimulation programs? Ovarian stimulation strategies have been improvised from the past 20 years. Previously, the age, basal FSH, and also the prior response to stimulation were taken into account before starting the stimulation protocols. But with the inclusion of the ovarian reserve markers like AMH and also AFC, we are able to categorize or differentiate our patient into different groups so that we can predict their response and also explain their prognosis to the patients. So with the inclusion, now the ovarian stimulation protocols have come a long way from individualized controlled ovarian stimulation. Ovarian stimulation protocols have come a long way from they have come a long way for individualized. We are doing now individualized controlled ovarian stimulations. So by incorporating these ovarian markers like AMH and also AFC, combined with age and also the BMI of the patient, we have categorized the patients into 3 groups. They are hyper responders, normal responders, and also poor responders. So hyper responders are those when the AMH is more than 3.6, and when they have more number of follicles, that is more than 15 follicles. The AMH and also the AFC are in the normalcy. We categorize them into normal responders. So whenever the AMH and also AFC are low, that is less than 5 follicles, then we categorize them into poor responders. Here the main treatment, here the main concern is how do we treat each group of these patients. So in high responders, whenever we look into the high responders, the important thing to note here is the safety of the patient. So to avoid OHSs is the main concern in this group of patients. In normal responders, the key word is optimization. So we need to optimize our ovarian response in such a way so that we avoid cancellation at the same time, and also we prevent OHSs. And poor responders, the main thing here is we need to reduce the treatment burden and also reduce the cancellation so that we can give maximum outcomes to these patients and avoid cycle cancellation. So in good prognosis women or in normal responders, whenever we take a success in ART, it depends upon the efficacy and also efficiency. Efficacy is increasing the cumulative live birth rates. Efficiency is how we are able to decrease the negative events. That is how we are able to decrease the multiple pregnancies, how we are able to decrease OHSs, and how we are able to minimize our abortion rates or the miscarriage rates. So we know that there are many predictive factors for pregnancy in ART, but the one positive predictive factor which we have been talking is the number of oocytes retrieved. So how can we improve the efficacy in a good prognosis woman or the normal responder is increase in the number of oocytes. Increase in the number of oocytes, we have more number of blastocysts and more cumulative live birth rates. There has been a lot of study or research going on as to what gonadotropin to use, which gonadotropin is better, how does it perform, how to get the best oocyte yield and all. So we have so many studies which have seen comparing the oocyte yield with different gonadotropins. They have shown that whether we use a recombinant FSH or a highly purified HMG, the clinical pregnancy rates or the ongoing pregnancy rates are the same. But what is the advantage of recombinant FSH is we can retrieve more number of oocytes. That is, the oocytes which are obtained are higher with recombinant FSH when compared with highly purified HMG. This is a randomized trial, that is the MEGASET trial, comparing the highly purified HMG and also recombinant FSH in an antagonist cycle. Here they have used 150 units of highly purified HMG and also 150 units of recombinant FSH. The conclusion was that the ongoing pregnancy rates are similar between HP-HMG and also the recombinant FSH. But however, the recombinant FSH, it yields more number of oocytes than the highly purified HMG, but the patient safety should also be taken into account. So because there is a flexibility of giving a GnRH agonist trigger and freeze-all, so this would be using recombinant FSH would be a better option. So there has been a lot of debate going on what kind of gonadotropin we use. So any gonadotropin we use, it should give us the maximum outcomes. So whichever regime is chosen, it is important that the gonadotropin preparation used is of a reliable and consistent quality so that it optimizes the likelihood of IVF success. It was proposed when using a recombinant FSH, we use a recombinant FSH which is filled by mass technique so that it improves the number of oocytes retrieved and also improves our clinical pregnancy rates and the implantation rates. There were doubts whether stimulation per se increases the aneuploidy rate. This was a study conducted by Labata et al. Where it shows that stimulation during an ovarian stimulation does not increase the aneuploidy rate. So we have come a long way. That is, there was a paradigm shift from the GnRH agonist protocols to the GnRH antagonist protocols. So most of the centers worldwide now, they use GnRH antagonist protocols. There were 45 RCTs which were comparing the antagonist to the long agonist protocols. What they have found was there was no evidence of a statistically significant difference in the live birth rates or the ongoing pregnancy rates. But what is the advantage of using GnRH antagonists is it decreases the OHSs. That is, we have a flexibility of giving a GnRH agonist trigger and doing a freeze-all strategy. So the GnRH agonist trigger have taken an upper hand on antagonist protocols have taken an upper hand on the agonist protocols. This is a recent study where they have seen the efficacy of FSH alone. They have combined FSH plus LH, FSH plus HMG, and also FSH plus HCG. And they have seen, because we are personalizing the ovarian stimulation protocols, they have combined this and they have done a meta-analysis. What are the conclusions from this meta-analysis is, administration of FSH alone resulted in high number of oocytes retrieved than when combined with FSH plus LH or HMG. Embryo number and implantation rates were higher when HMG was used instead of FSH alone. So combining FSH and HMG, we get more number of embryos and implantation rates are also higher. LH addition to FSH, it decreases the FSH need. That is, number of the dose of FSH is decreased, and also pregnancy rate was significantly higher when LH is added to FSH in certain groups of patients. So this is a study where they have grouped the patients according to the ovarian response. Group A was having 1 to 3 oocytes. Group B is 4 to 9 oocytes. Group C is having 10 to 15 oocytes, and Group D is having more than 15 oocytes. So the cumulative live birth rates usually increase with increase in the number of oocytes. But here what we are more concerned is, whenever a patient is having 1 to 3 oocytes, I would categorize them into a poor responder. 4 to 9 oocytes would be a suboptimal responder. 10 to 15 oocytes may be an optimal responder. Greater than 15 oocytes may be a hyper responder. So if 4 to 9 oocytes is suboptimal, that is, what is the suboptimal response? Either it should be an optimal response or it should be a poor response. What is the suboptimal response, or what is a hypo response? This can be explained by this slide, which shows the assessment of ovarian sensitivity to FSH. So here, when we take patients of same age, think that we have 2 patients of same age, we have same BMI, and also they are having the same AMH also, and same number of antral follicles. We give the same stimulation protocol and also the same dose to both of these patients. But the first patient responds normally. That what we have expected, she responds normally, and her follicle output rate, which is the ratio of the pre-ovulatory to the small antral follicles, is good. It is approximately 40 to 60%. And so that I would term this patient as a normal responder. So she has responded exactly as what we have predicted. But the second patient, we have given the same dose and also the same stimulation protocol, but this patient is having a follicle output rate of only 20 to 30%. That is, she had a response which is unexpected of her. We didn't expect this response. We were expecting a normal response from this patient. So why is this happening in many of our patients? We have the next marker, which is the Follicle-Oocyte Index, which is a new marker of efficacy, where the ratio between the number of oocytes retrieved at oocyte pickup and the number of antral follicles is taken at the start of stimulation. Usually it is from 0 to 1. A normal FOI means greater than 0.5 is that at least 50% of the antral follicles have translated into oocytes. Low FOI means less than 50% of the oocytes have translated into 50% of the antral follicles have translated into oocytes. What are the possible causes of this low Follicle-Oocyte Index? They may be because of low gonadotropin starting dose, maybe because of the genetic or environmental factors, maybe because of the asynchronous follicular development, or technical issues involving triggering or during the pickup. Whether we take a follicular output rate or a follicular oocyte index, it is important for us to understand these terms. A patient with a good ovarian reserve may have a poor ovarian response, and a patient with a poor ovarian reserve may have a good ovarian response. But what is happening? Why are we getting these more number of patients who are having hyperresponse? This hyperresponse is because of the polymorphisms in the FSH receptors and also in the LH beta receptors, which are seen. And also there is other thing, which is a variant of beta LH receptors. So hyporesponders are a woman with normal ovarian reserve, but they have responded in such a way that is unexpected of them. They have the same reserve, but they have different sensitivity to FSH and LH. So most of these patients who have a hypo-response, studies have shown that they have a polymorphism of Ser680, FSH polymorphism of Ser680. Usually this homozygous serine is usually seen in 20% of the normal responders, but whenever in hypo-responders, about 60% of these hypo-responders have this polymorphism. So what happens when there is this polymorphism? So this study shows the FSH consumption in variants of Ser680 and also in beta-LH variants, there is an increased consumption of FSH whenever these polymorphisms are present. So what do we do with these hypo-responders? So to avoid this confusion of hypo-responders and also the poor ovarian responders and also poor ovarian response, and also to explain the prognosis to these patients is very difficult. So this Poseidon group has come with a new concept of detailed stratification of low responders. They have given a poor ovarian response to a low prognosis concept. So what they have done is they have divided the patients into 4 subgroups based on the following quantitative and qualitative parameters: age and the expected aneuploidy rate. They have taken ovarian biomarkers, that is AFC and also AMH, ovarian response if a previous stimulation was performed. So what is the aim of this Poseidon classification? It helps us clinicians to counsel the patients as to what their prognosis would be and establish a working plan to reduce the time to pregnancy. So here in the Poseidon criteria, age is taken as 35 years because it is in most of the studies, it is 35 years, and also more than 35 years, maybe there is a decrease in the oocyte yield. So here we have in Poseidon group 1, young patients less than 35 years who are having a good AFC and also AMH, but they had a suboptimal response in their previous cycle. Poseidon group 2 is patients who are more than 35 years of age with good AFC and also AMH, but they have a suboptimal response in their previous cycles. Poseidon group 3 are the young patients less than 35 years, but these patients are with poor ovarian reserve, that is AMH and also AFC are very less. In Poseidon group 4, we have older patients more than 35 years with a poor ovarian reserve. So what do we do? How do we go about in these patients? So from group 1 and also group 2 patients, so these are young patients, but they have a poor or a suboptimal response in their previous cycles. So how do we tackle this unexpected impaired ovarian response? So how to manage a hypo response? Is it we either, how to manage this is, do we increase the recombinant FSH dose or add recombinant LH to these patients? So this is a recent study which was shown by Carlo Alvegi, which shows that in hypo responders, adding recombinant LH would give us better number of oocytes and also improve the implantation rates. So when is this recombinant LH started? It usually in this study, they have started at 150 IU on stimulation day 8 of the cycle. So whenever increasing the dose of recombinant FSH would not suffice, but adding recombinant LH to the dose of recombinant FSH would give us the better results. So they have shown that when recombinant FSH is added to recombinant LH, there is a higher implantation rate and also the higher clinical pregnancy rates are seen. So here we can see that while we are adding, we can see that while we increase the FSH dose and also we have given the LH supplementation, we can clearly see that by giving the LH supplementation, we are able to increase the number of oocytes, we are able to increase the number of mature oocytes, and also implantation rates and pregnancy rates are also increased. So this has been a Cochrane database, Cochrane library we have taken, where they have combined all the studies as to what is the dose of FSH that has to be taken as a cutoff, or above which dose it is not very beneficial to the patients. So they have seen a dose of 300 IU versus 150 IU, 400 or 450 IU versus 300 IU, and 600 versus 450 IU. So these analysis of all these studies have clearly shown that 300 IU has significantly given more number of oocytes than compared to 150 IU. But when we take 400 or 450 and also 600 IU compared with 300 IU, they have comparable outcomes, showing that increasing the dose does not benefit to these patients, but 300 IU would be beneficial by adding recombinant LH. Here also we see that the cycle cancellation rate was higher when 150 dose were used, and With 300 IU, the cycle cancellation rate was lower. And similarly, the 600 and also 450 IU have similar comparable results to that of 300 IU. So these studies have shown that increasing the recombinant FSH dose over 300 IU will not give us better results unless we unnecessarily we are increasing the burden and the treatment cost on the patients. So what does it do while we are adding LH to this patient? How does it enhance our outcomes? Whenever we are adding LH, there is more of androgen production in the theca cells. These androgens move to the granulosa cells and they make the granulosa cells more sensitive to FSH and increase the FSH receptors, so that whatever the FSH dose we give is FSH dose we give will give us the better outcomes. So how are we about to go in this group of patients? Whenever older patients in more than 35 years. So this also was proposed by Carlo Alvegi in 2018. This was given in Fertile Sterile 2018. So when we take patients between 35 to 39 years, only 35 to 39 years of age, adding recombinant LH to recombinant FSH would give us a better implantation rates. So there are many studies where in an antagonist protocol you can add 75 IU of recombinant LH started on stimulation day 1, or you can add 150 IU of recombinant LH from stimulation day 6 to 8. So this will give us a better implantation rates. But what about these group of patients, that Poseidon group 3 and also group 4, where the patients are having a very poor ovarian reserve? In patients with a very poor ovarian reserve, recombinant LH, adding recombinant LH would not give us more beneficial results. But here, Geostim would be a better option for these patients. What is this Geostim? It is a dual stimulation protocol where the patient is stimulated both in the follicular phase and also in the luteal phase of the same cycle. So how do we do this? Is start the gonadotropins from day 2 of the cycle. So they are continued day 2 of the cycle in a GnRH antagonist cycle, and it is usually continued till the trigger. Then the ovum pickup is done. So a gap of about 4 to 5 days is given after the ovum pickup, and then the second stimulation is started in the luteal phase. The same regimen is followed in a GnRH antagonist protocol. Gonadotropins are started, and whenever there is a follicle reaches 14 mm, GnRH antagonist is started. GnRH agonist trigger is given, and the second ovum pickup is done. What they have found here is, by seeing the follicular stimulation and also the luteal phase stimulation, the addition of luteal phase stimulation, it significantly increased the final transferable blastocyst yield compared with follicular phase stimulation alone. That is, we are getting more number of eggs, so that we have more number of euploid blastocysts to transfer in these patients with poor ovarian reserve. So what is the influence of age on oocyte quality? We are talking more of age and also the quality of the oocytes. So why is it that oocyte quality is decreasing with increasing age? Because there is a decrease in the mitochondrial function, so the fueling energy to the oocytes is decreased. There is a granulosa cell apoptosis which is increased with age, and also there is an increased oxidative stress which is occurring with more than 35 years of age. So there is a decrease in the oocyte quality. So as all of us know, with increase in the number of age, with increase in the age, the number of oocytes also decreases. So this was the same study by Sunkara, where she has shown the association between the oocytes and also the live birth rates. Here we have, here it shows clearly that with increase in one oocyte, we can increase our live birth rates. So she has shown that there is a critical benefit of getting one oocyte more will increase the live birth rates. Here in 40 and over years, at 4 to 6% is increased, and 38 to 39 years, it is increased by 8 to 12%. So it is very useful in poor ovarian reserve patients that even getting a one oocyte may translate into live births. So with increasing age, there is a decrease in the oocyte quality. There is also a decrease in the implantation rates. There is a decrease in the fertilization rates. So, but we have this pre-implantation genetic diagnosis, which is a new tool which has come up. So by doing this pre-implantation genetic diagnosis, we can select the euploid embryos, because as age advances, the aneuploidy increases. So in these patients, if we select the euploid embryos and transfer them, so we can decrease the implantation rates. We can decrease the age-related effect of implantation. That is, transfer of euploid embryos, it maximizes the IVF efficiency by eliminating the age-related decrease in implantation. So implantation rates can be increased by transferring the euploid embryos. And also pre-implantation genetic testing with aneuploidy, it reduces the time to pregnancy, because it allows us to select the euploid embryos, and also we can transfer these euploid embryos in less possible attempts. Here we can see that the time to pregnancy has also decreased. So when there is non-PGDA, in non-PGT cycles, it takes 14 weeks for a woman to get pregnant, whereas using PGT, it is only 7 weeks. So hyper-responders are the women of young age. They have AFC more than 20, AMH is greater than 3.5, and most probably they are PCO. What is the objective? Is prevention of OHSS in these patients. So there were many studies as to what protocol should be used in hyper-responders. So many the meta-analysis have shown that GnRH antagonist protocols are better in hyper-responders, because we have a flexibility of giving an agonist trigger, and the oocyte and also the ovarian hyperstimulation syndrome can be reduced by 50% in these patients. So whenever we are giving a GnRH agonist trigger, how does it act? The GnRH analog, it displaces the GnRH antagonist from the receptors in the pituitary, and there is a release of FSH and LH, which is more of a physiological peak, which stimulates ovulation and also final oocyte maturation. What happens when we give a GnRH agonist trigger? Here we can see the comparison between GnRH agonist trigger. This is a natural cycle, and also compared with HCG. GnRH agonist trigger has a sharp spike, and also it is cleared, like short half-life, within 20 to 24 hours it has. But when we take a HCG trigger, the HCG trigger has a high peak, and also it takes long. It takes about 10 to 14 days for it to get cleared. So there are many meta-analyses, there are many studies which show that GnRH agonist triggering reduces the incidence of OHSS. What are the benefits of GnRH agonist triggering for ovulation? So there is a decrease in the OHSS. There is an increase in the more metaphase 2 oocytes. There is a higher fertilization rate. There is a higher nuclear maturity. There's a higher implantation rate, higher LH receptor expression in the cumulus cells, and it avoids the negative impact of HCG on oocyte quality. And also it is more physiological. It enables an endogenous FSH surge. But what happens when we give a GnRH agonist trigger? Why is there an inadequate luteal phase? As you can see here, whenever we give a HCG trigger, it takes a long time. It takes a long time to travel, maybe 10 to 14 days. But by the time corpus luteum comes to rescue, and the luteal phase is recovered in HCG cycles. But whenever we give an agonist trigger, so because of its short half-life, there is also a decrease in the LH activity, and there is no rescue of the corpus luteum over here. There is a deficiency of LH, and so there is an inadequate luteal phase. There have been different strategies which have been put up for luteal phase support after GnRH analog triggering, giving high doses of estrogen and progesterone until 10 weeks of pregnancy. With HCG, so many people have tried so many protocols. Some have used multi-low dose 450 IU. Some have used a single dose of 1500 IU. Some has done a dual triggering, GnRH agonist plus 1000 IU of HCG. Some have given a daily microdose. Some have done a luteal phase coasting. So some have also used recombinant LH, multiple dose, 300 IU, but it may be very expensive. Some have given GnRH agonist multiple doses daily. So different researchers have followed different protocols to rescue the luteal phase. The most commonly followed is after giving a GnRH agonist a trigger, giving a hCG of 1500 IU on the day of oocyte pickup has increased. I mean, it has more comparable clinical pregnancy rates as that of a hCG trigger. So they have given a GnRH agonist trigger. On the day of oocyte pickup, we give 1500 of hCG. So there is also a decrease in the OHSS rate, and also the clinical pregnancy rates and ongoing pregnancy rates were on par when compared with hCG trigger. So what are we doing? What are we progressing to? We are progressing to an OHSS-free clinic by segmentation of IVF treatment. We should use a GnRH antagonist protocol. GnRH agonist can be used as for triggering, and freeze-all strategy can be performed. Elective frozen replacement cycles for all. So what are the take-home messages? Results should be presented as cumulative live birth rate as the primary outcome for initiated cycle. Patient characteristics and also the ovarian reserve tests like AMH and AFC should be taken to individualized stimulation regimens. Conventional stimulation within acceptable limits is safe and efficacious. Recombinant gonadotropin preparations are more potent and result in an increased oocyte yield. Cumulative live birth rate significantly increases the number of oocytes retrieved, serves as an important prognostic variable in IVF. In hypo-responders, addition of recombinant LH could be optimal therapeutic option when the FOT is less than 50%. The freeze-all strategy is promising in hyper-responder after a GnRH agonist trigger, but it requires additional RCT to identify which subgroups of patients would benefit. Pre-implantation genetic testing, pre-implantation genetic testing for aneuploidy, and also elective single embryo transfer to reduce multiple pregnancies and shorten the time to pregnancy and also a healthy single delivery. Thank you for your patient attention.
Ma'am, thank you so much for a wonderful lecture on improving the outcomes in ART. With this, I would like to open the audience questions. You can ask ma'am questions directly by unmuting your mics, or you can ask to the chat box. Any questions to ma'am, doctors? Ma'am, just one comment from Dr. Tahir. Thanks for the lecture.
Yeah, pleasure. Most welcome.
Ma'am, there's a compliment from Dr. Ankita Shah. Wonderful lecture. Thank you so much.
Thank you.
Lots of compliments, ma'am. Very nice presentation. Thank you so much for sharing this.
Thank you.
Any questions to ma'am, doctors? Any comments? Ma'am, yes, ma'am. Ma'am, there's one question. Is the recombinant LH a hope for pregnancy in those who are aged above 35 years, ma'am?
Yes, we can add recombinant LH to these patients. Most probably you can start them from day one of your stimulation with 75 IU. So hopefully these patients respond well and will get good live birth rates.
Thank you, ma'am. Ma'am, the next question is from Dr. Numadevi Shivkumar. Do you use intralipid routinely for all patients to improve the pregnancy rate, ma'am?
I don't use routinely all these intralipids, but my exposure to intralipids is a little limited, but I use only in selected group of patients.
Thank you, ma'am. And the next question is from Dr. Vijayalakshmi Rangaraj. What is the role of adjuvants in stimulation?
I see one more also about the role of use of testosterone. They were asking something. Okay. Yeah. See, testosterone is the gel which we have come. It is very useful for these poor responders. Usually, we start from the cycle before cycle when we are starting on with the IVF. So the previous cycle we usually start from day 5 or day 6. It is usually 12.5 milligrams, which is gel which has to be applied, and so I give it usually twice daily, and this usually continues till the stimulation is started.
Thank you, ma'am. Ma'am, the next question is again from Dr. Numa Devi. I think it's an extension of the previous question. What is the indication for intralipid, ma'am?
See, intralipid, I have very limited this thing, but maybe in patients of recurrent implantation failure, I'll be using the intralipids.
Thank you, ma'am. Ma'am, the next question is, what is the role of pyridostigmine?
What is the minimum and maximum dose of recombinant LH for poor responders we have? So I am getting this question. 1 second.
Okay, okay.
Minimum and maximum dose is like 75 and 150 are the doses we have. Usually if you start from day 1 of the cycle, use a 75 IU of LH. If you start on day 6 or 7, 150 IU would suffice.
Any more questions, doctors, to ma'am? Ma'am, how to prevent empty follicular syndrome?
See, whenever you have an empty follicular syndrome, it is either you didn't give your HCG trigger properly. That is the first thing which we usually see. We have a genuine empty follicular syndrome where if you do the patient for the next time also will get an empty follicular syndrome. But for the first time is you need to see whenever you are doing an ovum pickup for the first ovary, you didn't get eggs. So you need to see that whether the HCG trigger is given properly or not. So whenever you give a HCG trigger is not given properly, usually you get an empty follicle. So the next time, or sometimes we have we do beta HCG and see how the levels are. So you can see in the follicular fluid also how the levels are, how the HCG levels are. If they are good, like if it is showing you that the HCG trigger is taken properly, then maybe we can give a dose of other trigger and do the pickup again. Or if you want to do it in the next cycle, you can just change your stimulation protocol and give the trigger in the presence of you to prevent that.
Thank you, ma'am. Ma'am, when it comes to poor responders, Dr. Vasan Ali asks, is it mandatory to use r-hLH or can we substitute with HMG?
So whenever it comes for poor responders, here our main concern is to get more number of oocytes from them. So more number of oocytes means we can use a recombinant FSH, but studies have shown that when we add recombinant LH, we have good quality of oocytes, and at the same time we get more number of oocytes. So it would be prudent to add recombinant LH than adding HMG for these patients.
Thank you, ma'am. Ma'am, there's one question on day one, r-FSH with 5 international unit r-hLH should be started in poor responders. It will be increased or decreased?
I would like to say here, whenever there is a poor responder, that is whenever you say a Poseidon group 3 or group 4 patient, don't start them with a recombinant FSH of 50 IU. It will not be any helpful for you. Start them on with 300 of recombinant FSH and add on them with LH. So that will be added benefit for you, and you will get a good response from them. Less number of low or FSH dose will not give you the good results.
Thank you so much, ma'am. The next question is from Dr. Vijayalakshmi Rangaraj. What is your opinion on using OCPs before stimulation, and for how long would you use it?
Yeah, you can use OCPs before stimulation, maybe for 14 days. But after that, you need to have a washout period of about 5 to 6 days, and then start on with your stimulation.
Ma'am, Dr. Vasan Ali, thanks you so much for answering the question, ma'am.
Pleasure.
So if there are no further questions, thank you so much, ma'am, for, I think ma'am actually agreed for this lecture again, as usual, at a very short notice, and you went to a lot of depth to cover all the facets of this very interesting topic, ma'am. And I hope the audience also had a great time listening to you. We hope to have more topics from you, ma'am, in the coming days. Thank you so much, ma'am, on behalf of Field Healthcare. Ma'am, there's one question from Dr. Bizar Gan. Sorry, ma'am. What is your opinion on inhibin A and B paternal lymphocyte antigen?
Sorry, but I have no experience with paternal lymphocyte antigen transfer. Inhibin A and inhibin B, we don't routinely do over here. So sorry for that. I don't have any experience of paternal lymphocyte antigen transfer.
Ma'am, again, another question from Dr. Noma Devi. Which protocol is good, ma'am? OCP priming or estrogen priming?
I would say estrogen priming would be better than OCP priming. So estrogen priming would give you a more synchronous cohort of follicles. So that would be a better option than OCP priming.
Thank you, ma'am, so much once again.
Okay.
I'm sure there are a lot of questions. What I'll do is I'll collect the questions and mail it across to you, ma'am.
Sure. Fine. Sure. Thank you, Kiran. Thank you.
With this, I would like to ask Kumar sir to give the vote of thanks. Maybe. I think he's logged off, ma'am. So again, thank you so much, ma'am, on behalf of healthcare.
Yeah.
So,
thank you so much.
Ma'am, with your kind permission, can we share the webinar link of the recording to the doctors?
Oh yeah. Sure. No problem. Yeah.
Thank you, ma'am. Thank you so much.
Yeah.